I am Ankit Grover from Apollo Hospital, second year resident. I am presenting a case of Mrs. XYZ, 50-year-old female, resident of Delhi, housewife by profession, postgraduate, history given by the patient and her husband, and seems enlightened. History taken on 1st August 23. My patient presented with frothy urine and pedal edema for last 2 weeks. I would like to date my history back to September.
ये बताओ, what if you are confronted with a lady? देखो OPD में ऐसे ही मिलेगा.
जी सर.
If you are confronted with a lady who is 50 years and presents with pedal edema and facial puffiness, that's all.
Yes sir. Pedal edema frothy urine.
Frothy urine. So what comes to your mind? कि मैं ये चार इस तरह से मैं सवाल पूछूंगा.
Sir, I would like to rule out
because you know in nephrology, for all practical purposes, 90% of your diagnosis is based on your history. There is nothing really in the examination.
Yes, sir.
That will help you. Of course, there are points. In some cases, there are lots of things. But by and large, the majority of the patients is very little to add. Unless you know the investigations. Investigations will finally tell you what exactly it is. So what did you think in terms of 50 years old with frothy urine and edema?
Sir, I would like to ask question about nephrotic syndrome in this patient. So I would like to rule out any cardiac issues in this patient, any GI, liver-related issues, hypothyroid, 50-year-old female presenting with edema.
Right.
Then, as per the nephrotic part, I would like to ask any issue of hematuria, decreased urine output, any recent vaccination or recent any infection.
Okay, so that you will go into the history.
Yes.
Right?
I would like to date my history back to September-October 2007, when my patient was around 34 years old, when she had fever, which was high grade and not associated with chills or rigor, and was relieved by medicine, and was associated with joint pains, which involved the knees, elbow and the shoulders, and did not involve the small joints, and was relieved by medicines. There was no diurnal variation in fever, and the episode subsided over the course of antibiotics and painkillers over next 10 to 12 days. Patient continued to have joint pains on and off and used to take painkillers for the same. There was no morning stiffness in the joint pain or no fleeting nature of the joint pains. After about a month or so, patient started to develop swelling over both the feet, which was insidious in onset and progressive, initially involving the feet, which gradually progressed in knees over 1 to 2 weeks. There was no puffiness of face or distension of abdomen. She noticed frothing of urine and also had an episode of dark colored urine, which was present throughout the act of maturation and resolved spontaneously. This was a single episode and there was no urgency, frequency, passage of clots or dysuria or burning maturation, no loin pain as such. She went to a local hospital and was told that she had leaking of protein in urine and some blood cells in the urine. She remembered the creatinine to be 1.6 at that time. She was also told that she had high blood pressure and was started on tablet Telma. Her ultrasound was told to be normal at that time. This is in 2007. There was no history of decreased urine output, skin rash, diarrhea, throat pain or vaccination. No history of photosensitivity, mouth ulcers, hair fall, small joint pain, morning stiffness or fleeting type of joint pain. No history of palpitations, tachycardia, chest pain, dyspnea on exertion or significant weight loss. No history of jaundice, blood in stools, hematemesis, distension of abdomen, blood transfusions, bleeding clear or clay-colored stools. She was referred to Apollo Hospital and was advised to kidney biopsy in 2007. And a few tests were done, details of which she doesn't remember. She remembers the 24-hour urine was collected and she was told to have a protein around 2 to 2.5, exact value she doesn't know. She underwent renal biopsy in November 2007. Biopsy and post-biopsy period was uneventful and she did not have hematuria and was discharged after 1 day of hospitalization. After the biopsy report, patient was started on tablet Omnacotin 60 mg. And with treatment, she told that her pedal edema and frothy urine subsided over next 2 weeks and joint pains also improved. She continued to take tablet Telma along with some calcium and multivitamin tablets. On a regular follow-up, she was told that her urine reports were normal and her creatinine came down to 0.8 after 4 to 5 months of treatment. After that, she was told that the dosage of Omnacortil was started. The doctor had started reducing the dose, and she was on alternate day till October 2008. When she developed an episode of edema along with frothy urine, and her urine examination showed presence of protein. Again, a 24-hour urine collection was done, but the details are not known to the patient. But she remembers to be a creatinine to be 1.3 or 1.5. She was again started on tablet Omnacortil 60 mg along with endoxan every day. Patient had improvement in her symptoms and was continued on Omnacortil along with endoxan for some days. She was told that she had normal renal function and normal urine examination on follow-up. She took endoxan for a period of 3 months and it was then stopped by the doctor. During this period, she was told to monitor her CBC regularly, which she says was always normal. There was no history of fever or urine infection during this time. She continued the tapering doses of Omnacortil and she remembers her medicine was stopped somewhere in early 2010. She was asked to take tablet Telma and calcium regularly. She remembers she had gained weight and facial swelling, which gradually decreased over next to 2 years with regular diet and exercise. In 2012, patient developed deranged blood sugar levels, for which she was started on oral drugs and her blood sugar levels remained in control. There was no history of striae on abdomen or hump on neck or any shortness of breath. Patient was lost to follow and remained well till 2019. She says she monitored her KFT, which was normal, and visited a nearby physician, but she did not visit a nephrologist. She continued her medicine for blood pressure and blood sugar and multivitamins. She says that BP and blood sugar were under control. In 2019 or 20, patient had an episode of pedal edema and frothy urine. There was no associated hematuria, fever or joint pain or decreased urine output. She took Omnacortil 60 mg once a day for 1 month on her own and stopped. And no investigations were done at that time. She did not meet any doctor at that time. Patient remained alright till July 2023 when she complained of fever, pedal edema and shortness of breath on exertion. Fever was low grade, not associated with chills or rigor or burning micturition or cough or loose stool, and was released by tablet augmentin taken for 5 days. After a week of fever, patient developed pedal edema and frothy urine. She got herself evaluated and was told to have protein in urine along with a creatinine of 1.9. She was told that her blood pressure was found to be high, which was around 160/100, and was given another drug for blood pressure control. There was no history of joint pains, dysuria or decreased urine output or any rash. There is no history of alternative drug use. There is history of on and off NSAID use. There is no history of shortness of breath, chest pain, palpitations, unequal swelling or pain in the lower limbs. Patient underwent a second kidney biopsy on 2nd of August and this 2nd of August. Coming to past history, there is no history of bronchial asthma, tuberculosis or renal calculi. No history of similar disease in the family. Patient is vegetarian with normal sleep, bowel and bladder habits. No history of substance abuse. Menstrual history. Patient attained menopause around 2.5 years back. Had no menstrual abnormalities earlier. She is a mother of 2 children. First child is 19 years old, full-term normal vaginal delivery, and second child is 22 years old. Sorry. And that was a cesarean section due to cord around the neck.
So that's the history.
Yes.
Okay. Will you sum it up in say 4 lines?
Yes, sir. A 50-year-old female with no known comorbidity had bipolar edema with frothy urine and an episode of hematuria in 2007 following fever and joint pains. She had a creatinine of 1.6 and proteinuria, and 24-hour urine protein showed around 2 to 2.5 gram per day. And patient after a biopsy was started on steroids and achieved remission within a month. She had a relapse in 2008 with a creatinine of 1.3 or 1.5 and was started on endoxan. She was off the treatment by early 2010. She developed features of diabetes and remained on OHA. She had features of steroid toxicity in the form of weight gain, facial swelling and deranged blood sugar levels. She was lost to follow-up and had a relapse in 2020, for which she took Omnacortil for 1 month, 60 mg on her own, and stopped the treatment. She remained well till July 23 when she had fever. Following after 1 week, she had pedal edema and frothy urine with raised blood pressure and underwent kidney biopsy on 2nd August.
So why don't you think the first episode is very different from the rest of the episodes?
Yes, sir.
So how do you analyze the first episode in 2007?
Sir, in 2007,
when she was 30 years old or something?
Yes, sir. So that is more like a presentation of a nephritic syndrome.
Why do you say nephritic syndrome?
So patient presenting with hematuria, with hypertension and
she had high colored urine.
High colored urine, deranged urine functions.
बेकसूर खाने वाला डार्क यूरिन है कि एक्चुअल कोर कलर्ड यूरिन है? हाई कलर्ड तो बहुत सारा हाई हो जाता है.
When की blood, she said कि blood जैसे ही था urine में. Okay. But that was only one episode. I also asked the periods.
One episode is enough.
Yeah, to make her to have. Yes. But high colored में वो high मतलब
एक तो high colored urine.
Yes, sir.
एक hypertension.
Hypertension.
Right.
And ulcer and renal dysfunction. Creatinine of 1.7.
Okay. So that was nephritic syndrome, right? And how do you explain the associated joint pains and fever?
Sir, that can be.
Why did you think of a autoimmune disease, a systemic disease that time?
Sir, it can be infection-related glomerulonephritis, post-infectious GN.
post-infectious.
देखो बेटे ऐसे सोचना होता है. अब तो तुम्हारे पास पूरे कोर्स है.
हाँ जी सर.
तो वो तो अलग हो नहीं सकता कि वो अलग था और ये सब अलग है.
Yes sir.
है ना? This is why I asked you specifically this. You should have the maturity to, when you present to the examiner, filter out some of these symptoms which don't seem to fit, or you can just mention them in passing and forget it. No, I thought you were going to present SLE, presenting as nephrotic syndrome, because that is what the first episode was.
Yes.
It looked like a 30-year-old lady who has joint pains, hypertension, raised creatinine, proteinuria.
Yes,
Classically will fit into systemic lupus, right? And then subsequently she. So what is, you don't think that is lupus?
Sir, but there are no extrarenal symptoms of
joint pain extrarenally है भाई. Fever extrarenally है. Mouth. अच्छा you tell me, 2 years, how many lupus have you seen? Quite a bit.
Yes sir.
How many had mouth ulcers? Here, why are you putting forth that this is essential? कि mouth ulcer नहीं थे. That is no meaning. No?
Yes sir.
So it was a class 3 or class 4 lupus that time. Do you think the entire history can still be lupus?
No sir.
Why not?
एंडोक्सिन भी दे दिया भाई.
एंडोक्सिन भी किसी ने दिया. You know, if you have ऐसे सोचो, why are you focused? I'm sure you know the biopsy report, right? And it is not lupus. So this is the problem when you come for such a class. This is what I've seen repeatedly. Whenever I come, the man knows the diagnosis and therefore he tries to fit everything. Suppose it was class 2 lupus that time, and she was given adequate doses of steroids. Don't you think lupus will go into remission? And she became alright. Then she flares 1 year later because the treatment was stopped, and then she received endoxin with steroid. So that goes into remission. And now, what has happened to her? Relapse of what variety? Membranous. अगर membranous हो गया तो इसी में you will not show any systemic features, not really. And she can. I thought you were presenting lupus, presenting as nephrotic syndrome. No? तो ये सोचा नहीं तुमने?
Sir, but recurrent joint pains का एक बार starting में
तो दवा खाई उससे बढ़िया. अच्छा, you tell me, all of you, we've all seen lupus is treated by a lot of people. They start with joint pains.
Yes.
They take some steroids. They take some Ayurvedic medicines. They become all right. Then 1 year, HCQS 1 year चलता रहता है उनका ऐसे. फिर वो थोड़े दिन better रहते हैं. फिर आ जाते हैं symptoms. फिर है ना. Finally they come with nephritis, lupus nephritis to you, and that is probably 5 years or 3 years after the start of lupus. Right? So malar rash, oral ulcers, if they are present, very good. It doesn't rule. If they are not present, doesn't mean no lupus. No?
Yes.
Right? So now tell me, what is against lupus in the whole history? Or have I convinced you that this is lupus? Now you have to convince the examiner that this is not lupus. So how do you post-infective glomerulonephritis hoti? What is unusual about post? Suppose we agree that is post-infectious glomerulonephritis. Correct. So post-infective glomerulonephritis doesn't relapse. Very few of the post-infective glomerulonephritis will relapse, right?
यहाँ पे तक 4-5
relapses है. तो वो आपने जो बोला कि post-infective GN हुआ पहला एपिसोड वो गलत था.
प्लस उसका टाइम कोर्स क्या होता है? कौन सा infection and then when do you get the GN?
Mostly it is post-streptococcal GN.
When do you get the infection? When do you get the GN?
But after the throat infection, it is usually 3 weeks, and after a skin infection, it is 4 to 6 weeks. इसका time duration 1 month.
But the joint pains and the other symptoms are also now lining up at the same time as the presentation of the GN.
Yes.
So if you are going to line up an infection and the GN together, what would you say is the more likely? IgA. So फिर वो बना
ठीक है ना.
और कौन सा GN बनेगा? So आपके differential में just by the story.
Yes, sir.
Remitting, relapsing.
It can be IgA nephropathy.
Okay.
Then lupus nephritis. Then it can be MPGN. Then
MPGN. Okay.
So presenting with
30 years में which glomerulonephritis are commonly seen?
Sir,
which is the commonest that we
IgA
see?
common.
IgA. Okay.
Sir.
Then
और इसमें sir FSGS
is MGN commoner or FSGS commoner? Is minimal change commoner or FSGS
adults
commoner?
FSGS is common.
Is commoner.
Yes, sir.
And
then उसके बाद membranous.
then
minimal change.
then minimal.
Yes, sir.
Right. So you don't think any of these can fit into that?
FSGS can also, but sir, seeing the history of 16 and 17 years, FSGS might have landed up to ASRT by now.
Correct. So I would agree with you. That's a point which says that it may not be FSGS. Can it be MGN?
Sir, membranous usually presents with massive proteinuria. They can be present with subnephrotic also. It can be membranous also, sir.
It can be membranous.
Yes, sir.
What is against minimal change?
Sir, minimal
She responds so beautifully to 4 weeks of steroids and just goes into remission. As relapse,
कौन सा membranous
4 हफ्ते में तो कोई membranous नहीं जाएगा. तो अगर मेरे को पहला diagnosis रखना है idiopathic glomerulonephritis में, I would keep minimal change. The only thing is that high colored urine.
Yes, sir.
The only thing is that hypertension. But then we know minimal change disease in adults is very different from minimal change disease in children. Right? And how is it different?
Sir, it can also present with the hematuria, renal dysfunction, and hypertension. Minimal change.
Correct. So more prevalence of hypertension.
Yes, sir.
There may be hematuria to nahi kahenge, but RBCs in the urine.
Yes,
Right? And there may be a raised serum creatinine. So if a minimal change disease presents with raised creatinine, what are the 3 things that 3-4 things you will look in to explain that high creatinine?
Sir, we should rule out renal vein thrombosis in these patients.
नहीं यार, कहाँ renal vein thrombosis minimal change होती है? ऐसे नहीं है कि no. It's not common. You must have seen a lot of minimal change. How many renal vein thrombosis have you treated? None. ऐसे सोचा करो जो मैं देखता हूँ वही होता है ना? You are not in a small center जहाँ पे 2 patient रोज आ रहे हैं, है ना? And you see fair spectrum of people, right? So why think of commoner things which can cause renal dysfunction?
Volume depletion.
Correct. Number 1 is volume depletion. Right? They are nephrotic. All the volume is outside. Barrow में, ascites, right? So they are volume depleted. Serum albumin is 1.5, and they develop raised creatinine. Once the albumin becomes better, they come out of it. What else?
Infection superadded.
ठीक है. Sepsis.
Sepsis.
Right? So what type of sepsis do minimal change disease people get, and why?
Pneumococcal peritonitis is common in these patients.
Pneumococcal infection, very good. So why is it common pneumococcal and not some other Klebsiella or E. coli?
Capsulated organism infection.
ऐसी क्या बात है? What happens in
due to hypoalbuminemia?
No, hypoalbuminemia, amyloid has severe hypoalbuminemia. They don't develop pneumococcal infections. Complement losses, right? So they are more prone to capsulated organisms getting. What is the commonest site of infection in children?
Peritonitis.
Peritonitis. And why peritonitis? Because they have ascites out of proportion. Children in adults versus the children, in adults the edema starts from the face and goes to the legs.
Yes, sir.
Right? Facial puffiness followed by period. In children and young adults, ascites is commoner. For some strange, nobody knows why, but ascites is common. जहाँ भी ascites या fluid accumulation हो, वहाँ infection होने के chances ज़्यादा होते हैं, है ना? So they are prone to this. So what do? You want to prevent minimal change from developing pneumococcal infections. What do you do?
Sir, prophylactic antibiotics.
नहीं यार, prophylactic नहीं, vaccinate them. Right? And when will you vaccinate?
Sir, it is done after the age of 5 years of age. के बाद we give straight third PSV 13, and then after 8 weeks we give 23.
Suppose he is on 60 milligrams of steroid or 40 milligrams of steroids. Will you give or not give?
Less than 10 milligram per day.
ये कहाँ लिखा हुआ है? देखो मैं बताऊँ, जब भी क्लास के लिए आओ, ये पहले all these classes used to happen only at PSRI, है ना? तो गंगाराम की एक लड़की आती थी, वो हमेशा ऑक्सफोर्ड टेक्स्ट बुक लाती थी, हैं, और वो खोल देती थी, कहती थी ये आप गलत बोल रहे हो सर, ये इसमें ये लिखा हुआ है. As far as I remember, pneumococcal vaccine you can even give when you are on high dose steroids, right? And the live vaccines are contraindicated. The pneumococcal you can give. So what are the live vaccines that you know?
Measles.
तो एग्जामिनर ऐसे ही पकड़ लेता है क्योंकि तुम्हारा कोई वो उसमें है नहीं.
Measles, mumps, rubella, these are live vaccines.
Right. So tell me now, one cause is hypovolemia, second cause is sepsis of raised serum creatinine. What else?
Creatinine becomes 5, 6, 7.
देखा फिर क्या सोचो? Bilateral involved vein thrombosis होता नहीं है, तो कहीं तो वो बोलते फिर से, हैं?
In an adult with minimal change,
creatinine बढ़ गया,
5, 6 मतलब 1.5 वाला तो चलो
डायलिसिस की स्टेज ही आने लग गई, सोचो क्या हो जाएगा? ATN.
Well described. Minimal change disease with ATN.
Then you have AIN, secondary to furosemide, diuretic surgery. They call AIN. That is another cause for raised creatinine, right? So minimal change disease in adults can present like that, and you can easily say, अगर आप overplay नहीं करते ना joint pains, तो एग्जामिनर ज़्यादा नहीं इस पे वो करता, तो आपको माइंड में डायग्नोसिस बनाना है पहले. If you present this case as lupus, no examiner will say no. If you present it as minimal change, no examiner will. But if you present it as FSGS, membranous, every examiner will object. कौन सा FSGS है जो स्टीरॉइड से अकेले बिल्कुल ठीक हो जाता है, अगले 1 साल ठीक रहता है, या 2010 से 2019 तक ठीक रहा? कोई नहीं रहेगा. कौन सा मेम्ब्रेनस है जो 4 हफ्ते के स्टीरॉइड में रिमिशन में चले जाता है? So important history to ask when you are dealing with nephrotic syndrome are a couple of things. One, अगर जैसे infection के साथ related, तो is there a time gap between the infection and the onset of proteinuria? If there isn't, then you think of IgA nephropathy. If there is, then you think of post-streptococcal infective glomerulonephritis. अगर nephrotic syndrome है, तो every infection will precipitate it, right? So you can put that infection and joint pains as one entity. You can say probably सर कोई viral हुआ होगा, उससे ये joint pains हुए थे, and I would not really be too much worried about these joint pains.
Because over 20 years didn't happen again.
Yes.
Right? So had it been lupus, जब भी relapse होता है उसमें कुछ तो होता extrarenal. ये थोड़ी हुआ सिर्फ proteinuria हो गया उसमें. Right? So that is against lupus. So even though I raised that possibility, you should have countered me. है ना? कि नहीं sir, the problem
में कभी नहीं हुआ.
हाँ, he just probably there was some viral infection, and as a result of a viral infection, she got into this joint pains and had first episode of her nephrotic syndrome. Right, and we know most minimal change disease patients will have relapse with the onset of infection. Right. ठीक है, तो अब हमने क्या सोचा, right? So that is how it is. So what is against membranous being the first possibility in this patient? अच्छा चल ऐसे करते हैं. Now you tell us what the examination tells you. We've analyzed the history as much as we could, right? But
sir, with current examination.
हाँ current ही बता सकते
जी sir. Patient is conscious, cooperative, alert, and oriented to time, place, and person. Pulse rate is 90 beats per minute, right hand radial artery. Blood pressure is 140 by 90, right hand spine position. Respiratory is 40 per minute. Pallor is present. Pedal edema up to ankles and shin below the knees. Fitting type of edema is there. There is no cyanosis, clubbing, lymphadenopathy or rectals. Nails are normal. Rest of the examination is systemic.
So there is nothing in the really in the examination.
Edema, sir, and that hypertension.
Okay. Right. So now tell us what is your syndromic diagnosis and
sir, type 2 could be possibly nephrotic syndrome with nephritic kind of a presentation.
what presentation is nephritic? That high colored urine and hypertension.
And
वो तो हमने thread by discuss कर लिया
nephrotic
है ना. If you want to put an nephritic syndrome, then how is she having so many such episodes?
Sir, can this be a combination nephrotic nephritic syndrome?
Yes, why not?
Sir,
Correct. So then you can say that it's probably. So what is the disease that you would fit into a nephrotic syndrome?
Sir, IgA nephrotic.
Correct. And if somebody asks you why, you can say the commonest glomerular nephritis we are seeing now.
Yes, sir.
Aren't we?
Ji, sir.
And this is how it can be. Right? So, what type of histology will you expect with this type of a history in IgA nephropathy?
Sir, in IgA nephropathy, you would see mesangial expansion, then there can be endocapillary proliferation, then there will be IgA deposits, plus or minus C3 in the.
नहीं, इस पेशेंट की बात हो रही है.
हाँ जी.
ये तो क्रिसेंटिक भी हो सकता है, सब कुछ हो सकता है. IgA nephropathy is any histology in which IgA deposits are predominant.
Yes, sir.
Right? Have you heard of minimal change disease with IgA? No? ऐसे कैसे हो गया यार? IgA is just a full spectrum
with EM with complete diffuse food process
effacement. Minimal change disease with IgA is that. Minimal change के अच्छा variants बता यार. फिर तो अगर ये नहीं पता फिर वो tell me what are the variants of minimal change disease that you know?
One is IgM nephropathy.
Very good. So उसमें IgM होता है.
IgM होता है.
एक IgA भी होता है. और क्या होता है?
IgG.
हाँ?
बाकी नहीं बस IgM और बाकी तो
IgM और IgA एक और
आप कर सकते हो मिनिमल चेंज में. आप IgG भी बोल सकते हो. कैसे? आप कैसे बोल सकते हो?
क्यों नहीं बोल सकते?
क्यों नहीं बोल सकते? लेटेस्ट क्या है? An antibody that has been shown to be present in minimal chain disease and shown to have small globular IgG deposits. Why does Retux work for minimal chain disease? Because there is no one. Membranous में एंटी फ्लावर है. मिनिमल चेंज में कौन सा है आजकल न्यू हॉट? 10 years ago it was flower, now hot on minimal change.
नहीं
सीजेसन का पेपर ना,
तो उसमें
सीजेसन में है, सीजेसन या जेसन, नेफ्रिन, एंटी नेफ्रिन एंटीबॉडीज, तो नया है वो।
तो IgG हो गया, IgM हो गया, IgA हो गया, कॉम्प्लीमेंट हो सकता है कोई, C1q होता है,
C1q नेफ्रोपैथी,
हाँ वो भी मिनिमल हिस्टोलॉजी के साथ प्रेजेंट करती है ना। तो how will you differentiate that this is minimal or one of these variants? आपने तो किया नहीं IF,
सर IF में डिपॉजिट
नहीं आपने IF नहीं किया, मिनिमल चेंज रिपोर्ट कर रहा है, तो how will you suspect that it may be one of these? These are diseases which don't respond classically to steroids. They don't work. Steroids don't work as good as they do in pure minimal change. जिसमें ये सब deposits नहीं होते हैं. Maybe IgM may be a little more towards minimal change. The IgA, the C1q, all these are less, right? And how will you know in a biopsy that this is not unlikely to be minimal and more likely to be FSGS that has been missed?
सर इलेक्ट्रॉन माइक्रो
नहीं यार, मैं तो कह रहा हूँ IF ही नहीं कर पा रहे आप, यू मे बी इन अ सेंटर, ये तो बता रहे थे कहाँ से हैं, तो वहाँ पे IF मिलेगा ही
सर। उसमें there is focal segmental sclerosis in FSGS,
नहीं, वो तो मिस हो गया,
मिल गया तो
हो गया, काम ही खत्म हो गया
जी।
How in a biopsy which is showing pure minimal change disease, for the pathologist he will say that likely, or you would say this is likely to be FSGS which has been missed. Why is FSGS missed on a biopsy?
So because कहीं there is patchy involvement.
Patchy involvement or deeper involvement?
Deeper involvement. Yes, sir.
Juxta medullary glomeruli से start होता है FSGS. तो आप जब cortex लेते हैं, you will miss that.
Yes, sir.
Often your do you see medulla in your biopsy? Or more likely no.
Cortex मिलता है.
Cortex ही होता है.
Yes, sir.
है ना? तो वो ग्लोमेरुलाई मिस हो जाते हैं जिनमें FSGS. तो क्या टेलटेल साइंस हैं बायोप्सी में जो आपको बताएंगे कि FSGS है? हो सकता है. One is glomerulomegaly, बड़े ग्लोमेरुलाई अगर दिखें, ठीक है, मिनिमल चेंज है, नॉर्मल है ग्लोमेरुलाई, they are bigger than the usual. Two, which is tubulointerstitial fibrosis or tubulointerstitial atrophy, right? And that also tells you that there is likely to be underlying FSGS. Three is poor response to steroids. आपने steroids वो classically respond ही नहीं कर रहा. Fourth is in the clinical presentation, if you have RBCs in the urine and hypertension or raised creatinine. ठीक है. So if there is hypertension, raised creatinine, mild hematuria in your, you are thinking कि ये शायद नहीं है pure minimal, हो सकता है कुछ. और अगर आप steroids दो और वो हफ्ते 10 दिन में ही respond कर रहा है और 4 weeks में respond कर जा रहा है adults में और 6 weeks में respond कर रहा है, आप कहोगे चलो minimal है ना. But if he is not responding, then you think, right? फिर बताओ आगे क्या बनाया तुमने डायग्नोसिस? You made IgA nephropathy.
सर पहला डायग्नोसिस था IgA नेफ्रोपैथी रहा था. Second we sir kept as FSGS and third we kept as MPGN and then leukocyte.
तो FSGS तो ये रूल आउट ही कर सकते हो.
Yes sir.
है ना?
Response.
हाँ. दूसरा ये बताओ मुझे कि यूरिन रूटीन नहीं तुमने बताया, isn't that nowadays considered part of your exam? Examination में ही बता देते हैं यूरिन.
जी सर. Sir urine should protein of 3 plus and 40 to 60 RBCs, no RBC counts.
Okay. So now
WBC 5 to 10. Okay.
So how will you say that this these RBCs are from the kidney, not from the draining tract
Sir,
in this
yes,
patient?
Sir, we need to take the urine sample, we centrifuge it for 5 minutes, and then we examine the supernatant in the microscope. We see for dysmorphia.
कौन से माइक्रोस्कोप
That
में
is
dysmorphic नजर आता है?
phase contrast में.
फेस कंट्रास्ट. तो जिस जहाँ पे IF हो नहीं रहा वहाँ फेस कंट्रास्ट कहाँ से आएगा?
नॉर्मल में भी देख सकते हो, अगर देखना आएगा तो नॉर्मल में
सिंपल
माइक्रोस्कोप
चीज से जाया करो.
सकता है.
पहली चीज 3 plus protein यूरिन.
Yes sir.
And likely that these are from the kidney. If there are RBC casts, then they are from the kidney, right? एंड ऑफ कोर्स फेस कंट्रास्ट की जरूरत नहीं है, आप अगर
देखोगे मिकी माउस ईयर्स दिख जाएंगे,
अगर आपको
अगर है असली का तो दिख जाएगा,
ठीक है. So these are things which will tell you that these RBCs are from the kidney, right, and therefore likely to be a glomerular region. And if you say these are glomerular region, then RBCs with proteinuria is IgA in today's time.
Yes.
है ना, ये बात है. तो ये अगर तुम बताओ ना तो एग्जामिनर कहेगा ठीक है भाई IgA nephropathy is a good diagnosis to, right?
And histology में क्या बनेगा इसका?
Histology
Based on the
में
history,
IgA
based on the
nephropathy
history.
doesn't mean anything.
IgA nephropathy में based on the history that you've already given us, what do you think the histology will show?
Sir, mesangial expansion.
Mesangial expansion तो हर IgA में होता है.
Deposition.
इसको एंडोक्सिन दिया किसी ने?
हाँ सर.
एंडोक्सिन क्यों देगा?
Presence तो उस टाइम पे
हुए होंगे ना.
but उस टाइम डिक्रीज यूरिन आउटपुट नहीं था.
क्रिएटिनिन तो बड़ा हुआ है,
क्रिएटिनिन 1.3
1.7
पहला ओरिजिनल वाले में था.
original.
बट किसी ने एंडोक्सिन दिया IgA को, चाहे जब भी दिया तो कुछ तो सोच के ही दिया होगा, तो मोस्ट लाइकली क्रिसेंटिक तो होगा उस समय, कि तभी एंडोक्सिन तक तो नहीं जा रहा कोई.
बिल्कुल,
मतलब एंडोक्सिन हाथ से निकलने के लिए IgA में क्रिसेंट तो बनेगा, खाली नहीं तो स्टेरॉइड से काम चल जाएगा, तो नहीं तो एंडोक्सिन हाथ से निकलने के लिए कोई भी कुछ भी कर सकता है. वैसे तो हम सब अपने करता धरता है, सो कोई पीछे सवाल पूछने के लिए नहीं है, बट यू आर थिंकिंग ऑफ इट. सो इसकी बायोप्सी रिपोर्ट भी है, करंट वाली आपके पास?
दोनों है. दोनों है.
बता दो क्या था पहले वाले में, क्या था और अभी वाले में क्या.
So 2007 वाली जो है, kidney biopsy shows 9 glomeruli. 7 glomeruli show mild increase in the mesangial matrix. Basement membrane thickening is not seen. 2 glomeruli show mild periglomerular fibrosis. Interstitium shows small focus of chronic inflammation. There is mild focal positivity for IgM in the mesangium, suggestive of mesangial proliferative nephritis.
Okay, so there was no IgA at all. So IgA तो नहीं था to begin with, right? Mesangial proliferative. फिर तो वाली बात.
Recent वाले में renal cortex with up to 7 glomeruli and 2 arteries. 4 glomeruli are globally sclerosed. The viable glomeruli appear mildly enlarged with no increase in cellularity, basement membrane thickening or crescents. One tuft shows a syncytial formation with adhesion to the overlying Bowman's capsule. However, no definitive segment of sclerosis is seen. Tubular atrophy in 20 to 25% of the cortex sampled, fibrosis and a moderate lymphocytic infiltrate. Artery include shows intimal fibrosis with reduplication of the internal elastic lamina and narrowing of the lumina. IF study shows 13 glomeruli, of which 5 are sclerosed, no immune deposits seen. Kidney biopsy shows features of chronic renal disease with significant global glomerulosclerosis with IFTA of 25% and vessel changes of hypertension. In view of the nephrotic syndrome present clinically, associated unsampled FSGS is a possibility to be considered.
Correct. Right. So this basically looks to be a mesangial proliferative GN, which has steadily progressed and now is in the chronic stage. Right.
सीरम एल्बुमिन कितना है इसका? लैब से पाते हैं, लैब से अच्छा पहले उल्टर डायरेक्शन से कर लेते हैं. आप क्या क्या कराओगे, क्या क्या भेजोगे?
सर प्रेजेंट एल्बुमिन इज 2.9.
ना वो तो ठीक है. सो अपन उल्टर डायरेक्शन से होता है.
तो ये बता कि फर्स्ट एपिसोड में लेडी तुम्हारे पास आती है, तो हाउ वुड यू हैव इन्वेस्टिगेटेड, व्हाट अदर टेस्ट वुड यू हैव डन बिफोर डूइंग अ बायोप्सी?
So I would have done a CBC, LFT, KFT, a urine examination, a 24-hour urine protein, then viral markers HbA1c, HCV, HIV, then ANA, anti-DS, DNA, complement levels, and ASO titers, and
You won't have
anti-plato antibody.
ANA में नहीं करवाते.
ANA,
Okay.
anti-DS, DNA, then plato antibodies और CN का दिया.
ठीक है, सब करते हैं. कुछ भी नहीं छोड़ रहा है.
एन का ही रह गया, एन का बच गया, एन का। ठीक है, ओके, ठीक है।
तो बता यार इसमें
क्या था?
Why were you totally wrong in your diagnosis? IgA तो निकला ही नहीं। So you know, these are points to learn. And what is to learn? To not highlight things which are tenuous. अब पता है क्या वो डीप कलर्ड यूरिन बोल रही है, क्या नहीं बोल रही है, बड़ा मुश्किल है बताना, ठीक है ना। तो उसको पासिंग में ही बता दो, क्योंकि कई बार क्या होता है, एग्जामिनर तुम्हारे से पहले एक और लड़का प्रेजेंट कर चुका होता है और वो हिमेचूरिया, हाइपरटेंशन और लूपस बना के गया होता है, ठीक है। तो जब तुम्हें दोबारा वही पेशेंट मिल गया, अब तुमने तो हिमेचूरिया को कर दिया, बिल्कुल ही नहीं बताया, तो वो नहीं कर सकते आप, राइट। So you will have to mention dark colored urine, but you can say, well, I thought it was probably related to the medicines he was taking, and therefore I didn't pay much attention to it. And had it been lupus, I wouldn't have had such beautiful response to steroids. In 4 weeks and 3 months, she is off steroid, then she is okay for next 2 years, and this is not how lupus behaves. Right, so therefore I would not think of lupus. So joint pains and that high colored urine, I would
viral infection.
बस छोड़ दूँगा मैं उसको, ठीक है। तो IgA तो I thought was a reasonably good diagnosis, but minimal change I thought was a very good diagnosis from the beginning. कि ये minimal change है, वो mesangial is nothing but minimal ही है यार, है ना। It's a that is पहले तो यही आप शायद थ्योरी खत्म हो गई है, minimal से mesangial, mesangial से FSGS. Pehले that was considered a spectrum, that if you have biopsied a minimal change at the age of say 15 years, and if the patient lands with renal failure at 45, it is progression of minimal change, which is of course no more true, right? But that is what, so probably mild mesangial proliferation was what she had, and that is why she has behaved like something in between minimal and FSGS.
Yes.
FSGS होती तो रिस्पॉन्ड ही नहीं करती अच्छा, मिनिमल होती तो प्लेटलेट नहीं बढ़ता, और दूसरा ये अब आपकी जो बायोप्सी फाइंडिंग्स है ऑफ सच सिवियर chronicity that won't have
अब बीच में उसको डायबिटीज एंड हाइपरटेंशन भी तो चालू हो गया, so वो steroid खा के उसके diabetes and hypertension, so now some of the vascular changes would be diabetic and hypertensive from that.
So now the diabetes is well controlled, is it?
Yes, sir. We got the HbA1c done, it was 6.1.
Okay. So now what is the plan of treatment for her? Now she has come with 4+ edema.
Yes, sir.
You are saying ankle तक knee तक edema. तो
अभी का वर्कअप क्या करोगे? बायोप्सी तो कर ली, बाकी वर्कअप
अब आगे क्या वर्कअप है? क्या क्या और टेस्ट कराओगे? अब
बेसिक यूरिन एग्जामिनेशन
वो हो गया। हाँ, हीमोग्लोबिन कितना है इसका बताओ?
सर 9.4,
9.4,
TLC 4000, platelet 1.96. Sir, we manage
renal functions, KFT.
बता दो। Sir, urea was 76, creatinine 1.9.
Right.
We manage the calcium.
वो सब क्या है इसके? कैल्शियम, फास्फोरस, यूरिक एसिड।
Calcium is 8.8, uric acid is 7.0, phosphorus is 5.6.
Okay.
We get our iron studies done. We'll start
Workup for anemia.
Then we see for iron, if there is iron deficiency, we replace iron. Then required we give erythropoietin after the iron deficiency is completed, and calcium supplement, vitamin D levels, and
इसमें तो phosphorus भी आई है।
इसमें phosphorus तो phosphate binder देंगे सर।
और क्या कराएं?
फिर हम bicarbonate कराएंगे।
Bicarbonate दोगे?
सर if it is less than 22 तो
अभी दे दोगे?
अभी देने में क्या नुकसान है?
अगर एसिडोसिस है तो
अभी मान लो 17 आ गया,
हाँ जी,
तो अभी दोगे? दोगे कि नहीं दोगे? रोज देखते हो?
देंगे सर।
देंगे। क्या प्रॉब्लम है? पेशेंट की जिंदगी में क्या तकलीफ है?
ये तो एडिमा शॉर्ट है।
सो
सोडियम और बढ़ेगा,
हर दिन यही होता है। इंसान आता है, मेरी तो जिंदगी में एक ही तकलीफ है, उसको क्रिएटिनिन 1.9 से कोई फर्क नहीं पड़ रहा है, उसको सूजन से फर्क पड़ रहा है। जी सर। आप क्या डोज शुरू करने वाले हो डायरेटिक्स का?
सर फिर अराउंड 20 बीडी से स्टार्ट
क्या
फिरोसमाइड
20 बीडी स्टार्ट करोगे, एंड सोडियम बाइकार्बोनेट कितने से स्टार्ट करोगे?
अगर 500 TDS
और फॉलो अप के लिए नेक्स्ट कब बुलाओगे?
2 वीक्स।
क्या लगता है क्या होगा उसका? वेट का क्या होगा, बाइकार्ब का क्या होगा, और उसकी तकलीफ का क्या होगा?
बाइकार्ब तो ठीक है, सेल इंक्रीज हो सकती है बिकॉज़ वी आर गिविंग सोडियम अलोंग विद बाइकार्बोनेट।
और आपको मालूम ही नहीं है कि आपको 20 के फिरोसमाइड पे रिस्पांस 1.9 पे आना भी है कि नहीं आना। सो मतलब इट इज अनबिलीवेबल द नंबर ऑफ टाइम्स people come to a different nephrologist only because the nephrologist made the right diagnosis, started the right overall course of plan, but there is no rush. बाइकार्ब से अगले 2 दिन, हफ्ते भर, 10 दिन में कुछ नहीं होना। It's a long term thing. At present, what is it that the patient cares about? Make sure you get that under control first. बाइकार्ब बाद में देते रहना, पहले एडिमा तो कंट्रोल करो, ब्लड प्रेशर तो कंट्रोल कर लो। Both of those are going to go for a toss for the bicarb. Plus, as you volume contract, your bicarb may get better by that only. You may not end up needing the bicarb. So don't start till you have edema under the right plan and you know that your diuretic dose is going to work for that patient. Once you know it is going to work, then okay, fine, bicarb still low, add it. But भर के वही होगा।
सीरम एल्ब्यूमिन कितना है इसका?
सर 2.9।
2.9, okay, right. So serum albumin is low, bicarb is low, edematous है पेशेंट आपका,
वो ओपीडी बेस के बाद में होता है।
हाँ ठीक है वो तो बिल्कुल। और क्या कराओगे अभी इसका? पैराथर्मोन कराओगे?
यस सर।
कितना है पीटीएच?
ओपीडी बेस कराया
नहीं अभी।
अभी वो फॉलो अप में।
राइट। सपोज इसका पीटीएच आ जाता है 1200, फिर
सर एट दिस स्टेज ऑफ क्रॉनिक किडनी डिजीज वी डोंट एक्सपेक्ट कि टर्शियरी हाइपोपैराथायरॉयडिज्म।
टर्शियरी तो बोला ही नहीं यार,
तुमने कैल्शियम फॉस्फोरस तुमने ही बताया, हमने तो खाली पीटीएच डाला। कैल्शियम तो आपने 8.4 है, कैल्शियम तो बोला ही, कैल्शियम 8.4 है, फास्फोरस 5 है, पीटीएच 1200 है।
फिर
जब पहले तो we control the calcium phosphorus levels, we'll give her active vitamin D, we'll get a vitamin D.
Right.
Then we
so give vitamin D, control calcium, phosphorus, and reevaluate the TTS.
Yes, sir.
And you may be surprised it comes down very well.
Yes, sir.
And don't need. Yeah. Okay. Will you do the normal vitamin D3 test करते हैं या no?
Sir, 25 hydroxy.
वो तो टेस्ट करते हैं, क्या करते हैं? वही कर रहे हैं।
25 hydroxy
दे रहे हैं या कर रहे हैं?
एक टेस्ट करो 25 hydroxy का।
25 कर रहे हो? क्यों भाई? हैं? और 125 नहीं कर रहे?
करते हैं सर, बट रेगुलरली नहीं करते।
करेक्ट। तो कौन सा विटामिन डी देगा इसको?
सर हम एक्टिव फॉर्म देते हैं
125 ना, तो दूसरा वाला देगा नहीं देगा? You think the other one is required or not?
But active
non-hydroxylated.
But we are already giving active ones.
So you don't need to give. Okay. There are some thoughts that you need to supplement the other vitamin D also. Because the vitamin D is not only active in bone, but also is required in all tissues for the functions. And therefore, generally, you will have to supplement if the vitamin D is low, both active form, which is what you give,
yes,
and the normal vitamin D, right? So PTH आपने कंट्रोल कर दिया इसका, और क्या करोगे? किडनी साइज तो ठीक ही होगा तभी बायोप्सी की है ना? So what are the indications of biopsy in small kidneys?
Small.
भी तो आप यही देखते हो, करते ही यही हो कि भाई किडनी साइज ठीक है, क्रिएटिनिन बढ़ा हुआ है, बायोप्सी करो। कोई प्रोलिफरेटिव जीएन हो गई, क्रिसेंटिक हो गई, स्मॉल किडनी है, फिर भी आप यू वांट टू डू अ बायोप्सी। क्यों भाई? कोई बताएगा तुम्हें? Oxalosis. Often you diagnose only on a biopsy. Otherwise, you will put him into a transplant, and the patient will finish off his new kidney as well. Okay. What are the other ways of diagnosing oxalosis short of a biopsy?
Plasma oxalate levels.
Plasma oxalate levels हो जाते हैं आराम से. यही तो बात है, बहुत मुश्किल है. It's not easy. What other sample can you take? Bone marrow. ठीक है, ये दो जगहों पे आप वो देखते हो. So that is one indication to do a biopsy of a small kidney. What other indication? Renal artery stenosis, right? To dilate or not to dilate, है ना? The classical indications of dilating a renal artery are.
Sir, the kidney size is more than 8 centimeters.
नहीं, मैं तभी तो कह रहा हूँ, साइज तो है ही नहीं.
वहाँ से पहले
क्लिनिकली क्या?
कौन सा आएगा?
Unmanageable hypertension, 4 drugs, flash pulmonary edema. The patient is coming with flash pulmonary edema, rapidly deteriorating renal function. ये 3 इंडिकेशन है. ठीक है. इसके अलावा चौथा इंडिकेशन ये है, if your kidney biopsy shows well preserved lung line, and then there is some point in dilating a small kidney की renal artery. Otherwise, there is no point. And these are soft indicators to do a kidney biopsy in a small kidney. Which solitary kidney would you biopsy?
Which solitary kidney do you always biopsy?
A transplant kidney. है ना? हाँ.
हर दिन biopsy करते हैं.
Otherwise, solitary kidney is a relative contraindication.
Yes,
right? तो इसलिए what are the other relative contraindications?
sir. For kidney biopsy.
Correct.
Sir, patient any bleeding disorder.
Yeah.
Then bleeding coagulopathy, thrombocytopenia, very obese patient.
Right. These are relative contraindications. Absolute contraindication तो कोई है ही नहीं by and large. Right? You can biopsy in all these situations. And you can do a transvenous biopsy.
Yes, sir.
And that is how you get over. ठीक है यार. केस तो तुमने अच्छा चुना. But biopsy पता होने की वजह से तुमने इसको इस तरह से कर दिया. ठीक है. और अगर कुछ है जिससे खास एक ऐसी बात बता जो तुझे लगता है इनको किसी को नहीं पता होगी. मैं तो यही बोलता हूँ इससे इसको है.
Anything that you did for this case or
Yes,
for
which
this
is thought यार
case,
ये तो मुझे पता नहीं था.
or you read something sometime which you think was significantly new for you, which if it was new for you, it will be new for them.
So everybody.
Case related कुछ PubMed, Google, कहीं से कुछ.
I was just reading there about IgM deposits on
Okay.
हाँ बताओ वही बताओ.
This one was in MCD IgM variant and early phases of FSGS and hepatitis C virus AMC essential mix and we get IgM.
Right. Correct. Mixed smell. Right.
Usually we see IgG.
So secondary causes of minimal change.
So there can be drugs, then
ड्रग्स नहीं बोलना ये
ना ये
एग्जांपल हूँ कि क्या अमोक्सिसिलिन से हो जाएगा. तुम कहोगे हाँ जी. ड्रग्स बताओ ना.
Sir, NSAID use, gold, penicillamine, they can cause minimal change disease and Hodgkin's lymphoma, allergic atopy, and
यही है. अच्छा, suppose a minimal change disease child develops relapses with infections. So often that is the problem. So how do you prevent that relapse?
Sir, prophylactic antibiotic
नहीं, प्रोफिलैक्टिक एंटीबायोटिक का वायरल फीवर हुआ उसमें एंटीबायोटिक देखेगा और कब प्रोफिलैक्सिस देगा? इन्फेक्शन तो कभी भी होगा, है? तो one of the recommendations is to give 0.5 milligram per kilo of steroid when the infection starts,
when the infection starts.
and the relapses will not happen, right? ये पढ़ लेना यार, शायद रिकमेंडेशन में है नहीं है, नहीं ये फैक्ट है ये, but this is how you can prevent relapses in minimal change disease. तो सब वैक्सीनेशंस पूरे आने चाहिए आपको, ठीक है? क्योंकि CRF में भी कर, CKD में भी करते हो और नेफ्रोटिक में भी आप करोगे, है ना? अच्छा बता, सेकेंडरी कॉजेज ऑफ FSGS.
Sir, secondary cause FSGS.
ये देखो ब्रॉड सवाल ये पूछे जाते हैं, ये केस में नहीं पूछे जाएंगे, ये पूछे जाएंगे उसमें जब स्लाइड देखोगे ना, तो बोलेगा क्या है डायग्नोसिस, तो आप बोलोगे सर इतने ग्लोमेरुला ये वो, एंड में आपको FSGS. Okay, so tell us what are the secondary causes.
Sir, drugs they are pamidronate, sirolimus, interferon alpha, then infections, HIV, parvovirus, parvovirus, then CMV infection, then
FSGS. Is FSGS more often primary or secondary?
secondary.
Correct. Right.
How do you differentiate?
Sir, primary FSGS usually presents with a nephrotic syndrome kind of a presentation, whereas secondary has nephrotic range proteinuria, but then it can be absence of edema, presence of hypertension, absence of dyslipidemia and lipiduria, and there can be renal dysfunction in secondary FSGS. Primary FSGS may not.
Why do nephrotics have hypercholesterolemia, dyslipidemia? Why do they have?
There is loss of the glycoprotein, glycoprotein lipase activity that gets. So liver tends to increase the.
The oncotic pressure is low,
Yes, sir.
and in order to compensate for the oncotic pressure, it makes more lipids so that the oncotic pressure is maintained. One reason is this. What else? Metabolism of lipids becomes low, and therefore the lipids go up. And should you treat this hyperlipidemia?
Sir,
You just have to treat the proteinuria. If the proteinuria goes away, so in what situations will you treat the hyperlipidemia?
so once the triglycerides cross 500.
Yeah, triglycerides is not the problem as much, right? You treat when the nephrotic state is not going into remission for a long period of time. So persistent proteinuria chal raha hai. These are the chaps who will develop thrombosis. These are the chaps who will develop coronary arteries, right? Because they are living with 4 grams proteinuria for several years,
Yes.
right? And why do they have renal vein thrombosis, the deep vein thrombosis?
Due to hypercoagulability. There is
Why
loss,
is there
there is
hypercoagulability?
loss of
That is what I am asking.
there is also antithrombin 3, protein C and protein S in urine. So they tend to be hypercoagulable.
And how often do you see that?
So when the albumin is very less than 2, we generally we see it.
Yeah. Low serum albumin is heavy proteinurics, and which is the commonest disease?
Membranous.
Membranous. And how often will you see in membranous? क्या उसका prevalence है?
25-30%.
नहीं बहुत ज़्यादा यार, तूने membranous तो कितने देख लिए होंगे? एक भी देखा DVT? एक देखा होगा, है ना? So why is renal vein prone to thrombosis more than the other veins? In membranous, you will see deep vein thrombosis in the calf,
Yes, sir.
or you will see renal vein thrombosis, but you don't see cavernous sinus thrombosis or why. It's something related to the flow in the
Stasis.
correct renal vein में slow flow है. That is what they cite. And if you have concomitant protein C, protein S deficiency, or antiphospholipid or something additional, then they tend to have more of DVT. And it's not common. It's about 4 to 5% of this subset of membranous glomerulitis, not the all membranous glomerulitis, right? And people, of course, are now trying. Those who are investigating this, कि भाई renal vein thrombosis or DVT actively, they will find some evidence of thrombus which is clinically not significant, and therefore several studies will show you 50%. ठीक है? तो और क्या कॉम्प्लिकेशन होते हैं नेफ्रोटिक सिंड्रोम के? अब नेफ्रोटिक सिंड्रोम आया तो पूरा ही कर ले उसको. Infections हो गए, they're more prone to infection, and now you know why they are more prone to infection.
Yes, sir, loss of complement.
Correct.
Then thrombosis हो गया.
Thrombosis हो गया.
Then we can hypovolemia, AKI.
Hypovolemia, AKI. ठीक बात है.
Then they can.
Then long term में lipids से problems होती हैं.
Coronary artery disease, stroke.
Correct. These are the chaps who are more prone to. So which patients will you anticoagulate?
Sir, it is recommended albumin less than 2.5. It is recommend with the high. If there is high risk, we go for warfarin.
नहीं तो high risk कैसे define करेगा?
So those who are more prone for CVD, stroke.
ऐसा कौन सा prone होगा? तो बस नेफ्रोटिक आ गया यार, उसका सीरम एल्बुमिन 2.5 है या 2 है, चलो.
Yes, sir.
तो और membranous etiology, will you put him on apixaban or something or no?
Sir, either low molecular weight heparin or warfarin is approved. There are no studies on.
नहीं यार, इसकी guidelines होगी. क्या है guideline? What do the guidelines say?
So TDO says there is a risk prediction tool.
Correct.
So we have to put the data
There's
and see what
पढ़
is
लेना.
the
हाँ, there's a risk prediction profiling.
Yes.
उसके basis पे आप decide करते हो कि इसको देना है नहीं देना. Right? क्योंकि मुझे याद नहीं मैंने किसी को prophylactically दिया हो. But of course, it doesn't mean that that's the correct approach. I may be wrong. And we do see, हम लोग तो देखते हैं, तुम भी देखते ही होगे यार, आते हैं thrombosis के साथ. But that shouldn't happen if you are using the correct tool. और क्या है नेफ्रोटिक सिंड्रोम? बस ठीक है, हो गया. ठीक है. और बता कुछ और? Anything you want to ask? This is a interesting history, I would say. Doesn't I could never
Run of the mill.
not run of the mill. अच्छा case चुना है. And she is now in the OPD, is it?
Sir, के follow.
Conservative management of chronic kidney disease इसको हम देंगे, है ना? और तो कुछ नहीं करना.
Immunosuppression करना.
देने का क्वेश्चन. ठीक.
Can this be कि पहले भी FSGS ही रहा होगा?
हाँ. और देखो FSGS में क्या डेटा है? 10 years में 50% reach end stage kidney disease.
Yes, sir.
That means 50% don't.
They don't.
They will take a little longer.
Yes, sir.
So she may be one of those who will take a little longer to go. She will go now. नहीं देखता.
25%.
हाँ, तो she is going to go into renal failure. So that is why. So good control of blood pressure, good lipid control, good diabetes control. Now she has diabetes. Right?
आजकल के favorites.
हाँ, आजकल के favorites. वो सारे ही लिख देंगे इसमें.
Favorites.
क्या है आजकल? What are new molecules?
SGLT2 inhibitors.
One. What else?
जो diabetic kidney disease progression में फिनरिनॉल.
फिनरिनॉल. ठीक बात है. इसका फंडस नहीं कराया तुम लोगों ने? फंडस भी करा लो.
सर ओपीडी बेस पर फॉलो भी आएगा पेशेंट. सेकंड को बायोप्सी हुई थी तो
सर तो फिर बोलते हैं तुमने नहीं किया.
बिल्कुल. तो एग्जाम में तो you are supposed to do. You have to, otherwise they will. So you must sit with your ophthalmologist and learn how to see your fundus. At least diabetic fundus देखना आना चाहिए. ठीक है. ठीक है भाई.